So our second speaker is Dr. Elif Dogu, who's a research associate in health data science from the School of Immunology and Microbial Sciences at King's College London. Thanks, Elif.
Thank you, Steph, for the introduction. Now you all know who I am. Today, I will talk about how do we use machine learning in different stages of the care pathway. Next slide, please, Hassan. So we use it, but why? Why do we use it? Our populations are aging now, so that increases the demand in our healthcare services. We need to be more effective. Also, along with that, we create data on a daily basis. With the technology that we have now, we routinely collect data, which creates an opportunity to be more proactive and more personalized. This also aligns with the priorities of NHS, which is moving from analog to digital, also moving from reactive treatment to disease prevention, and also to move patients from hospitals to their homes with remote monitoring as soon as possible to avoid some risks, obviously an approach which started with COVID-19. Next slide, please, Hassan. So the first problem that I used machine learning was to predict outcomes of chronic obstructive pulmonary disease patients. This was my PhD work, long time ago, I must say. The hospital wanted to know how long a COPD patient will stay in the hospital when they're admitted with an exacerbation. Exacerbation is like a flare-up, a sudden worsening of respiratory symptoms. A patient comes to the hospital saying that they're breathless and they're admitted. At the time of this admission, the hospital knows this information that you see on the screen, the clinical information on a patient, and they wanted a predictive model. We have this information when they come. We want to understand how much they will stay. So we needed a model for that. And at the time when we started this project, they had the data for 154 patients. So when you think about this data, we have patients as rows, and as columns, we have these clinical features. This is the type of data that you mostly see in clinical trials. This is just exactly collected for this purpose. So it's like, I must say, it would be like maybe 10%, 20% data cleaning. Rest of that was modeling. Next slide, please, Hassan. So we tried artificial neural networks first. But when you use artificial neural networks, you know about your output layer. You know what you want to predict. We want to predict length of stay of a patient, but what we're going to input. For that, there are many methods now for feature engineering in the literature. The first approach that we took was to use correlation, because correlation was very familiar with the clinicians. As a first model, a benchmark one, we got only the variables that were significantly correlated with length of hospitalization stay. And we choose this one as the first model. Next slide, please. Well, during the modeling phase, we didn't get so much performance. In my background, I have industrial engineering, which also includes systems analysis. So I proposed an approach for the second model. Why don't we make a systems map of these variables? How do these variables interact? These systems map, you create them based on subjective information coming from the experts, which are clinicians in this case. And when you create a systems map like this one with the relationships between the features, then you can make calculations to converge this system to a steady state, where then you can understand which of these variables are the most influential, most powerful ones in the system. Next slide, please. So with this method, we created a second model, let's say an improved model, but we don't have the results yet. It's in the next slide. So this second model gave us a bit of more clinical features. But we had model 1, model 2, and also we need to compare it. What if we input all the variables that we know in the model? So next slide, please. We tried we mostly focused on artificial neural networks because it was we could optimize the parameters of that. We also use other machine learning models like linear regression or subvector machines to make comparisons. But we got the best results with Model 2 with artificial neural networks, which was only 20% error on the actual length of stay values. So this was enough for the hospital to say that, okay, this model has a promising potential, then we can start a new project. We should collect more data from patients because the 150 patients that I say it's not enough actually. It's good to show the feasibility, but not enough for a validated model. So the hospital made a decision for this next project. So this was a success. But of course, what happened after the hospital started the second project? COVID-19, and it stopped. Next slide, please. This was the second project. This was my postdoc project at Queen Mary University of London at School of Electronic Engineering and Computer Science. We used millimeter wave radar sensors for remote health monitoring. This was a part of a EPSRC and NIHR funded project. We deployed these millimeter wave radar sensors to 18 retirement homes of older adults, and we collected their mobility parameters. And you can extract a lot from mobility, like occupancy, like sleep quality, their walking speed, also vital signs. So when you think about this data, for each of the participants, we have columns as features extracted from radar. But in rows, we have the values of these features for each minute. So it's and also the study was 6 months. For 6 months, minute data. So we can say high temporal resolution, and also it's a time series, and that gives you the opportunity to be proactive and personalized because you have the time series of each participant. And also in this case, since the devices create structured output, there's not much data cleaning really. You can directly use it in modeling. Next slide, please. So we extracted a lot of biomarkers from this study for the 6 months. How do they use the home? How are they active in the home? Also, their in-home gait speed. In-home gait speed is an important predictor of many risks, many health risks, especially risk of falls. When you feed this data to a machine learning model, we could get individualized fall risk profiles of the participants. Next slide, please. There's also another way to use these sensors to demonstrate that we use the timed up and go test, which is a well-recognized clinical test to understand the fall risk. So basically, it's like the patient starts sitting on a chair, they stand up, walk for 3 meters, turn, walk back, and sit down. While the patient is doing that, the clinician counts the time manually. If this total timing is less than 15 seconds, they say there's a risk of falls. This is the clinical procedure. But when you put a radar in the room, then you can extract much more enhanced mobility parameters. Then you can understand much more about what's happening during this performance. And when you only extract, just imagine this is not 6 months, this is only maybe 1 minute. So we could increase the temporal resolution a lot. For this study, it was 55 frames per second. So that gives us a very enhanced information on what's happening. Next slide, please. How did we use that? We made interviews with clinicians. And we understood that actually these 5 subtasks of the timed up and go test, standing up, walking, turning, sitting, these 5 subtasks, actually they're meaningful. Their timings, their individual timings are meaningful for different types of clinicians. But there was no automated way to get these timings. So we thought radar could be helpful in that. Next slide, please. We designed an experiment. We recruited 26 participants and we asked them to perform different types of timed up and go tests in a controlled environment. And we extracted many motion and energy features from radar, like spatial metrics, geometric features, 3D data from radar. And as I told you, very high temporal resolution. To do this task for segmenting, we used unsupervised deep learning classification method. We classified the frames that we had. And with this method, we could get more than 90% accuracy in classifying these frames. So with this unsupervised deep learning algorithm, which is actually specialized for radar outputs, we could segment the subtasks of this test, which was very useful for clinicians to make their decisions. Next slide, please. So the project that I'm working on now at King's, I'm back to COPD, which was expected because this was what my PhD is on. I'm working on COPD now. I'm doing predictive modeling for early risk detection of COPD patients from electronic health records. These records are the records of Guy's and St. Thomas's Hospital. There was a long process of getting ethical approvals to get access to that. That was also a challenge. But there's another challenge in working with electronic health records. Also, Ben said about it that it's fragmented. Electronic health records, they are not designed for modeling. Their primary purpose was to archive patient information, also the communication between clinicians, and perform some admin tasks like billing, prescriptions. They are not designed for modeling, but as health data scientists, we use them for a secondary purpose of modeling. But the data is not designed for that. So most of the thing that we do with electronic health records, for the previous 2 projects, I could tell you about how the data looks like. But for this one, when you get into electronic health records, you see tables as the lab tests, and numbers, and free text, and admission notes, discharge summaries, transfer orders. Sometimes their timings are meaningful, sometimes the content is meaningful. So where do we use machine learning here? We use mostly deep learning methods to extract this data for data parsing. So for this work, when you work with electronic health records, I can say that maybe the 10%, 20% of the job will be the modeling, but the first 70-90% is to first extract this data, parse this data, get the meaningful data from electronic health records. And we do this retrospectively. I mean, when we access the data, we use the historical data to make some predictions on the future. So in this case, we are late for the patient. But when these models are done and validated, what the ideal point that we want to reach is our electronic health records would be redesigned that they could feed into models automatically and in real time, so that when a patient comes to hospital, like in the first problem that I told you, when a patient comes to hospital with their symptoms and tests, when their tests are done, then you also get both the clinicians and the hospital management, the admin, they get predictions on how much they're going to stay, what's going to be the outcomes of this admission. That's the ideal point that we want to reach. That's all from me today. Thanks so much for listening.